Let's start with pancreatic cancer.
The pancreas is one of the organs in the digestive system that sits quite deep in the abdominal cavity. One of the most important purposes it serves is to produce enzymes, which are chemicals that help you to digest food. One cannot survive without a pancreas, so it's a very vital organ. I don't want to leave a message here that there is a particular symptom that can tell you you're having pancreatic cancer. No. To get early pancreatic cancer, you have to find it by chance.
Okay.
You could be in a road traffic accident. You
Yes.
could be in the protest in the streets and get hurt. And then you go to hospital and then the doctor orders a scan
Yes.
because of something else.
Yeah.
And then we find a tumor in the pancreas.
Hello, welcome to the One Health Lens podcast, Explained, where we take one topic and break it down. I'm your host, Dr. Dana Wangari-Gitao. Today, we'll be talking about pancreatic cancer. As always, we have an important guest. I think at this rate, he's the resident oncologist for the show. I'll let him introduce himself and we'll get going.
Thank you so much, Diana. My name is Dr. Andrew Odhiambo. I'm a medical oncologist specialising in gastrointestinal cancers, and I'm happy to be here again.
Absolutely. How's teaching going, university?
Teaching is going well.
Yeah.
A few struggles, high numbers of students, low numbers of faculty, but we're getting by.
We're getting by. Okay, let's start with pancreatic cancer. There's some who might not even know where the pancreas is, right? So maybe let's start with what is it, where is it, what does it do?
So the pancreas is one of the organs in the digestive system that sits quite deep in the abdominal cavity, somewhere behind the stomach, just a bit low, and it serves many purposes. One of the most important purposes it serves is to produce enzymes, which are chemicals that help you to digest food. The pancreas also produces many hormones that help to regulate our bodies. And one of the most important ones is something called insulin, which helps to regulate our blood sugar. So it serves many functions. One cannot survive without a pancreas. So it's a very vital organ.
Okay. I mean, my grandfather had pancreatic cancer. I mean, he didn't last, after diagnosis, he didn't even last a year, right? So maybe let's start off, and he's someone, the interesting part was, he's someone who, or at least he told us, he'd never smoked, never drank. In fact, he used to do a lot of hikes because he used to live in the village, walk a lot, right? So by the time he's getting this diagnosis, one of the questions my grandma, had was, how did he get here, right? I mean, he never even, or I don't know again, but even sugar was not something he'd take in his tea. So what would be the causes, or what kind of patients, first of all, do you see with pancreatic cancer?
So pancreatic cancer is one of those cancers which it even scares us as oncologists, because it's quite dreadful. When you Google pancreatic cancer, there's nothing good that comes on the first search page. It is a very deadly cancer because the survivors are very few. In fact, by statistics, at 5 years from diagnosis, less than 5% of the patients are alive. And usually a big chunk of them do not last a year. I'll give you some stats later of some study we did earlier this year. The pancreas being hidden deep inside the abdominal cavity, it's very hard to know when something is wrong. There's no such thing as early signs of pancreatic cancer, because by the time you're having any sign, including abdominal pain or sensation of itching or yellowness of the eyes or the weight loss, whatever symptom it is, it's almost always late. Okay? It's one of those cancers which doesn't have a good way to screen for it. So it's just one of those cancers that if you get It's like the way that guy in a casino can give you the bad card.
Yeah.
There's nothing you can do about it. So it's really challenging for us, the doctors. It's really challenging for the patients. Taking them through treatment is very, very emotionally taxing. Some patients even refuse treatment because of those scary stats. But things have changed over time, and we are getting better. We are not yet where we want to be, but definitely we're getting much better. So if you ask me what are the causes, as I said earlier, there's no single identifiable cause, but we talk more of risk factors. And some of the common risk factors include a chronic inflammation of the pancreas. We call that pancreatitis, which could be due to many reasons, including chronic alcohol use, chronic gallstones. These are stones that can be blocking the ducts in the pancreas. You can have infections that can cause pancreatitis. Some of the other risk factors include obesity, chronic use of cigarette smoking, and some other rare conditions that can be inherited in the family can result in pancreatic cancer running in families. It's not very clear. Many of the patients who you get, they tell you, I've never done 1, 2, 3, 4, 5, and then you find out they've had diabetes diagnosed in the last 2 years, and maybe that could be predisposing them to risk factors. We are now understanding better that the balance between the good bacteria and the bad bacteria in our digestive system plays a role in development of some types of these cancers, including pancreas and colon and liver and gallbladder. So it's a long list, but there's no single like big
this
thing you
is
could
it,
say,
right? I mean, you've mentioned sort of familial history, right? Because I'm always conscious that I could be at risk. So is it, if your family has had someone who's had pancreatic cancer, chances are, is it also, because I think there's other cancers as well, which, if you have a first degree relative with pancreatic cancer, then your risk is definitely higher. If you have clustering of certain types of cancers, and the three commonest are pancreas, prostate, breast, and ovary, those could be lumped together in a hereditary syndrome, which puts your risk quite high. We have patients who we've taken care of who have those types of syndromes where you find they're like 4 or 5 siblings with the same exact cancer coming from the same mother and father, and one of the parents had the same problem. Then that definitely cannot be ignored. And so then, I mean, going back, given that there's so much we don't know, and given, your experience, right? And you've said some of what you could look out for sometimes is the history of, the most obvious one I know is the yellowness of the eyes, but that's a bit later. Maybe abdominal pain, change in your bowel symptoms. Is there sort of a timeline? Last time you were here, you told us that, if you find yourself having acidity, or you're having H. pylori 8 times in a year, you question, is there something?
For pancreas, I don't want to leave a message here that there is a particular symptom that can tell you you're having pancreatic cancer. No. In fact, to get early pancreatic cancer, you have to find it by chance.
Okay.
You could be in a road traffic accident. You could be in the protest in the streets and get hurt. And then you go to hospital, and then the doctor orders a scan because of something else. And then we find a tumor in the pancreas. That could be your only chance of having cure, because the most effective treatment is to remove the diseased part of the pancreas, and that's usually very complex. Most of the time, by the time you have pain, and this type of pain, it's a weird kind of pain. It's mostly a nighttime pain. It's a pain that's deep in the abdomen, and sometimes people feel it as back pain. So it could go to the back and then kind of come up. So it can be confused with reflux. It can be confused with arthritis. some patients tell me, I have been going for physiotherapy for 6 months because of back pain.
Yes.
And that back pain is not arthritis, it's pancreatic cancer. And so it's a bit all over the place, but really, maybe what I could say is, if you have, let's say, chronic abdominal pain that you're not getting the right answers, then it might be time to do a CT scan. Another very important point which many people miss, even many doctors, my colleagues, they miss, is if for some weird reason someone comes to you with diabetes at the age of 70, you know, somebody who's lived a normal, healthy lifestyle, is not obese, doesn't have a bad diet, is exercising, and all of a sudden they have diabetes from nowhere, then start thinking, could they be having pancreatic cancer? Or if you have a diabetic patient who is very loyal, takes their medications every day, blood sugar always normal, always going to clinic, everything is always okay, and then all of a sudden their blood sugar is off the roof, and you can't explain why is all this blood sugar problem coming up now, start thinking of pancreatic cancer. Whether it makes a difference or not, you can be able to find it at least in a point where the surgeons can remove it.
Okay. So then that brings us to then the management, because then it's not even management, some of the investigations, right? What would it be? Because you've said screening now. So maybe we'll get better. I don't know. There's a lot of science now evolving around checking for defects in your blood. We call it liquid biopsy. Maybe that could shine some light in the near future. But currently, for effective screening, we don't have anything yet. Maybe I'll be traveling to Germany actually next week for the Congress on GI cancers. Maybe we'll get to hear new stuff, but as at now, no. But in case you're suspected to have or you're diagnosed with pancreatic cancer, usually it will be discovered when you do, usually it's a type of scan called a CT scan, which can actually show a swelling in the pancreas. Sometimes you'll find that at the time you're doing the scan, the cancer has already spread, unfortunately. And then we can then add on some blood tests, and then eventually the doctor has to take a small sample from the diseased area in the pancreas, and then the pathologist will tell us this is pancreatic cancer. So that's the usual channel of trying to get a quick diagnosis. I mean, okay, so it's been discovered, let's assume by chance. So management, because I know for my grandfather, he said he just wants to live the rest of his days peacefully. What's the management?
Pancreatic cancer it's very emotional, to be very honest, because the management can be very complex. And as I said before, we have to constitute a team of doctors to make the decision for you. So usually it will be an oncologist, and then you'll have a pancreatic or a pancreatobiliary surgeon, and then you'll have the other physicians and the pain specialist and the pathologists all on the same team. So we would sit down, we would look mainly at your imaging tests. Sometimes we even order more imaging tests, very complicated tests that tell us this tumor, can we remove it by surgery? And we look through very many criteria. I don't want to go into the details. And then we come up and say, excuse me, sir, this tumor, I'm sorry, we cannot remove it.
Surgery is not an option.
And we can even say, no matter what we do, it may never be an option. Or we can come back and say, surgery is not possible now, but if you have some treatment, then later we could attempt surgery. Or we could say, this is a nice, clean tumor.
It's localized here.
It's not touching any blood vessels. This we can remove now. And so those are the kind of decisions that we make. So if the surgeons can remove it, then you would go for surgery. It's a long 8-hour surgery. I won't go into the details too. But usually you'll have even 3 or 4 surgeons in the
Yes.
same theater working on you. And then probably would follow that with chemotherapy or radiotherapy or both. If you can't have surgery now, but you're potentially a candidate for surgery, then would give you chemo first,
Yeah.
and then you'd go for surgery later. And then if you can't do surgery now or never, then you're almost condemned to be on treatment lifelong. But at every stage we assess.
Yes.
Okay, I'll give you a short story of a gentleman who we've been taking care of now almost 3 years. He came, he was diabetic for the last 2 years. Same story, no risk factors, no smoking, no nothing, you know, very loyal. He did the CT scan. It said he had pancreatic cancer, and as usual, some of the healthcare workers who are not exposed to cancer sometimes can give patients misinformation. So he was told his cancer is stage 2.
Oof.
Only for him to come to me, and then we did the new scan, and I told him, my friend, your cancer is advanced. It's not yet stage 4, but based on what we are seeing, we might not be able to remove it by surgery, but we could try. So we put him on chemotherapy. The chemotherapy for pancreatic cancer can be quite heavy, but we've learned how to do it better. And I can tell you with certainty there are some patients who will complain of very minimal side effects, and they're able to do the whole 6 months and maintain a good level of quality of life. So we took him through the treatment. We did the first scan. It was still not, we're still not yet able to operate on him. He was so devastated. He had a lot of numbness in his hands and feet, but we encouraged him. His wife and daughter were very supportive. We did the other 6 rounds, and still at the end of 6 months of treatment, surgery was not possible. At this point, he was like giving up, like, what do I do? Will I die with this thing? Then, as I said, there's some utility in working as a team. So when we went back to his scans, we looked at them, and we sat down as a team. An idea just came up within the tumor board, and somebody said, well, can we give him some sort of targeted radiotherapy? And we were like, okay, that seems feasible. Okay, so we sent him for his PET scan. He met all the criteria, and we sold to him the idea. And luckily now we do have targeted radiotherapy in the country. On TV it's called cyberknife, but us, we just call it targeted radiotherapy. So we were able to send him to the specialist who took him through the treatment. He completed, and actually when we did his final PET scan, the disease was not to be seen. Was so he asked me, am I cured? I'm like, well, your PET scan says there's nothing. He was so happy. He was so happy that day. I remember in the clinic, he lacked words. They even said I need to go to his house for Thanksgiving and do mass and everything. And that entire journey, you know, it's almost 1.5 years of constant,
back and forth.
So what started out as a very hopeless situation, when you're told you have we use the word unresectable, which means you have pancreatic cancer that the surgeon cannot remove. That's like telling somebody, you know, just prepare for the inevitable. And those are the thoughts these patients deal with every day. Those are the dreams they have. They just dream of death and nothing good.
Yes, absolutely.
But when we gave him the news of what were the results of our treatment, I think even someone like the whole village.
Of course, you must. You call everyone.
Address to the nation.
Absolutely.
People, you know what? I am healed.
Yes.
And imagine, I think we're almost getting to 8 months after treatment.
Wow. And here we are.
And he didn't have to travel anywhere to get this treatment, just here in our beloved country, Kenya.
Absolutely. I mean, I like that story because in many ways it's a message of hope, but it's also, as you said, shows the local capacity as well. But it also highlights how individualized sort of cancer can be, no matter, even if you have the same diagnosis, how you'll react to certain treatment versus another person. It's different, true. Right? So it's everyone in their journey, right? So maybe the final question, because you did mention some research, and also part of it is we didn't address what kind of profile, right? Is it, So
obviously the patients aren't many. Yes. According to the Global Can Registry, which is a global registry that gives us the estimates of the numbers of cancer cases in every country in the world. According to the 2022 statistics, pancreatic cancer ranks number 12 in Kenya, with about 900 new cases every year.
Okay.
I'll tell you for free that there's another probably 900 cases that will go without ever getting a diagnosis. So it's there. 900 is not a little. Yes, we have 42,000 cases, but 900 is quite a big number.
Yes.
Most of the patients are male, almost 2:1.
Okay.
The average age is about 60, but we have a fair share of young patients who are mostly females in their mid-30s, early 40s, and we don't know the reasons for that. Majority of the older patients would be men. Majority of the tumors would be located, the pancreas has many parts. So usually in the bigger fleshy part, which is called the head, most of the tumors are there. And sometimes it's good if it's there, because then your eyes will get yellow quickly, and then you'll go to hospital and maybe you'll have a fairly earlier diagnosis. When we looked at the survival data, it wasn't very interesting. About 40% of the patients do not last a year. By 18 months, you've dropped that percentage. And by 24 months, you're left with only 15% of the patients. So those are very scary statistics, but we are getting better. I can tell you that for sure. We have patients now living even 4, even 5 years, treated locally with locally available treatment options and all the care that I've told you we can plan for the patients. So it's getting better.
Are there support groups? That's
an interesting question. So generally, support groups are driven by survivors, and this is not a cancer with many survivors. So I would not say that there's a specific support group for pancreatic cancer patients, because the cases are few and majority don't last for too long for there to be probably in centers of excellence or research centers, probably where numbers are more. But we understand the utility of having the support groups, because it's very important for our patients.
I mean, even just for the family members, I'm imagining, I can imagine, not even imagine, the experience of when he was first diagnosed, that conversation. If you don't have a medical person within, or maybe, depending on where you live, the access to your oncologist is not as frequent. Sometimes those initial moments for the family.
It's pancreatic cancer is one of those cancers which, when the patient is sick, the whole family is sick, the extended family is sick, the in-laws are sick. Sometimes we have to do like very long teleconsults with people dialing in from the US, some from Europe, just asking what's going to happen to our dad, what's the next treatment plan, what are we going to do. It can't be hands off. People don't come to clinic alone, they come with grandchildren, and everybody comes in.
The entire clan comes in. I mean, it's interesting. I mean, part of these conversations help, right? They really do help. And I'm thinking next time we definitely have to address a few more, but we also need to perhaps understand the different, because you mentioned a lot chemotherapy, radiotherapy, right? And maybe we might need to just have a session around
on
what
the actual treatment.
exactly,
Yeah.
right? And even if it's not specific to pancreatic, generally, what's a cancer patient? What would be the options, right?
So, just to make it maybe simpler to understand, you see, pancreas it's one disease, yes, but there are so many fine print that can make you very different from somebody else.
Yes.
So you can't copy paste your treatment plan onto somebody else. The doctors have to meet and we have to come up with a plan. When patients ask me in my office, so doctor, what are we doing? I'm like, I don't know. But we came to you, the doctor, how don't you know? I'm like, I have to meet with my people. We have to sit down. Let us sit down, go through your images. Let's discuss. You go home, digest, come back. I will have a plan for you, or at least some options, and then we pick what makes sense. One thing which people don't understand is, for example, if you have a cancer that the surgeon can remove, if we don't mentally prepare you for the fact that the surgery has a high rate of complications, or that even after that surgery, this % of the time the cancer can come back, so that you're making an informed decision, so that you don't come back and say, doc, you removed half my pancreas, but now it's back. So why did you bother removing it? Doctor, you gave me chemotherapy, but it's not working, or the cancer has come back. It's a step-by-step process. We have to manage expectations. We have to explain to patients, if we are doing this, this is what we are going to achieve. I tell my patients, I will give you this chemotherapy. 4 out of 10 times I can manage to make you from no surgery to surgery. It's not 100%. So then you say, okay, I'm gonna take that risk. I understand. So that when we come to the end and the result is not what we expected, I had already managed those expectations before we started. You can't do it by remote control or on autopilot. You have to work with your patient every step of the way.
It's a journey. It's a journey. Thank you for coming.
You're most welcome, Diana.
We'll see you next time.
Thank you so much. Thank you very much. Yeah.
Thank you. And thank you for joining us on the One Health Lens podcast.